Hello again, this is Kamran Popal. I'm a urology registrar and I've recently gotten a national training number, and this is just my notes and my experience. And the emergency scenario that we're doing now is a renal trauma station. So we've got a 37-year-old gentleman who has had a road traffic accident. He was struck from behind by a van driver, and ortho is attending to a fracture of his tibia and a fracture of his radius. Also, he's got extensive right flank bruising, and a trauma CT has been done on arrival but is not reported. How will you assess this patient? So this patient scenario suggests high likelihood of renal trauma, and I would prioritize to see this patient straight away. The assessment will use an MDT approach according to the ATLS A to E protocol, a concomitant ample history AMPLE. So ample history can be taken, which stands for allergies, medications and anticoagulants, past medical history such as urological history or single kidney, last meal, and events or leading to injury or mechanism of injury, and also blood in the urine. In A, I will see if the patient is talking, 100% oxygen, C-spine has been stabilized with triple immobilization. If the patient is not talking, airway compromise, anesthetist should be involved for adjuncts or intubation. B, respiratory breathing, respiratory rate, SATs, flail, chest, open wounds, signs of pneumothorax, where respiratory and thoracic team should be involved. C, heart rate, blood pressures, capillary refill times, heart sounds, ECG, 2 large bore IV cannulas should be placed intravenously, 2 liters of Hartmann's in 500 ml boluses if the patient's blood pressure is low, heart rate is high, and check the response and major hemorrhagic protocol if needed. In severe hemorrhage and shock and bloods including full blood count, Usenis, clotting, lactate group, and cross-match 4 units. D, neurological status and BMs. E, focus on examining the abdomen, looking for the extent of flank bruising, penetrating trauma, flank tenderness, and peritonism signs. Also look for any pelvic fractures. Also, we need to examine the external genitalia, looking for blood at the urethral meatus, testicles present in the scrotum, any signs of trauma, rupture, and also do a DRE on log roll to see if there's a high riding prostate, which would indicate and then appropriate escalation and involvement of the CCOT and ITUT. Okay, so next question is, trauma CT shows grade 4 renal injury. Would you like to perform further imaging? So the good answer to this is trauma CT has a non-contrast series and usually a portovenous phase at the abdomen or a nephrogenic phase at the abdomen. To assess renal injury properly and any other concomitant ureteric or bladder injury, I would like to do a CT urogram with an excretory phase and a CT cystogram. So, I mean, if the trauma is, if the scenario is directed towards renal trauma, you don't necessarily have to see CT cystogram, but in major trauma centers wherever I've worked, if there's blood at the meatus, you end up doing a CT, or a flank bruising, you do a CT urogram with excretory phase and a CT cystogram, because you just have to wait for a few more minutes and take another image to ensure there's no bladder injury. And obviously, pelvic fractures, there's not enough information, so that's why I've got an additional scan written over here. It's a CT urogram with excretory phase with a CT cystogram as well. Now, I'm going to clarify something. CT trauma has got a non-contrast scan and a portovenous phase at the abdomen, and that's usually the nephrogenic phase. And the reason is obviously you scan starts all the way from the head, the neck, and then when it's the chest, it's usually the arterial phase. By the time the scanner reaches the abdomen, the arterial phase is gone. So then you're looking at the nephrogenic phase, and that's the end of it, really. But we're actually wanting to wait another 5 to 10 minutes for the contrast to go from the nephrogenic phase into the kidney and get released into the ureters to look for any ureteric injury. So that's your CT urogram or excretory phase. And then wait for another, a total of about 15 to 20 minutes for it to reach the bladder to take another scan to see contrast pooling within the bladder and extravasation from the bladder to look for any bladder injury. So it's all about timing. You can add that to the trauma CT, because all of those phases come after the arterial, the portovenous or nephrogenic phase. So after that, the phase is your excretory phase, and then the cystogram, which is the phase in the bladder. Okay. What is the grading of renal injury? So the renal injury is graded according to the AA classification of renal trauma, which grades the injuries from 1 to 5. it's quite straightforward. So you can look at the grades. So grade 1 is being contusion or non-expanding subcapsular hematoma. Grade 2 is laceration less than 1 centimeter within the cortex. Grade 3 is laceration greater than 1 centimeter into the renal cortex. And grade 4 is when the laceration involves the pelicalceal system, or if there is a segmental artery or vein damage. And grade 5, unfortunately, is a shattered kidney or renal pedicle avulsion. Then, how would you manage a grade 4 renal injury? So I will come to it later down the line in my extra questions. So the way it's usually explained in most of the interview books, and the way I've written in these notes that I had initially prepared, is slightly different from what I prepared towards the end. So keep an eye on the videos later down the line, and I will tell you exactly what the management of grade 4 renal injury is. It's different for patients who are stable and unstable, and how you deal with the urinoma is also slightly different. But I would ask you to have a look at my videos later down the line. I can tell you the answer that I prepared here as well. So I would inform my consultant, would resuscitate with fluids and blood products, and escalate to HDU and ITU as necessary. If the patient has no vascular injury or it is contained, then patient can have bed rest, empirical IV antibiotics, close monitoring in the ICU and HDU setting with heart rate, blood pressure and serum blood gases to monitor HP, and an interval scan in 24 to 48 hours. Also, the catheter should be checked for any hematuria. If there is a vascular injury but patient is stable, angioembolization should be used. If there is uncontrolled bleeding and the patient is hemodynamically unstable, then nephrectomy may be indicated. And then for urinomas, usually no treatment is needed, but in large urinomas, ureteric stent can be considered. Actually, this was the question that this is my updated answer. So I thought this was the old answer, but this is how you're supposed to answer the question. So in stable patients, in unstable patients, and then urinoma usually doesn't need any treatment, but if large urinomas may need a ureteric stent, and also infected urinomas may be drained in radiologically separate. So ureteric stent is inside, and the urinoma, if it forms from the outside, percutaneous drainage with interventional radiologists. So what are the indications for renal exploration? So hemorrhagic shock due to renal bleeding, expanding retroperitoneal hematoma, pulsatile mass on laparotomy, renal pedicle avulsion, and bowel injury along with urinoma, which increases the risk of sepsis. Next question is that the patient starts spiking, temperature on day 2 on the ward. How will you manage this? So ureteric stent insertion after discussing with my consultant, and percutaneous drainage of urinoma under ultrasound or CT guidance. What are the indications of scanning stable patient with renal trauma as per EAU guidelines? So, number 1, penetrating trauma. Number 2, visible hematuria. Number 3, non-visible hematuria and single episode of hypertension. Number 4, decelerating mechanism. Number 5, clinical signs such as abdominal distension, flank pain or mass, or rib fractures. So these are EAU guidelines, scanning with renal. So when you look at the EAU guidelines, they don't all mention everything, but I've actually combined the interview answers from different interview notes as well as the EAU guidelines, and this is the answer that I've generated. This is the end of your renal trauma station, but do have a look at the extra questions and extra stations at the end. And I'm thinking of doing the whole video as one, so that you get all of the extra questions towards the end as a revision. If it doesn't turn out to be too long, because obviously I have to take breaks, but I will try to do it in one video. And do have a look at that, and that will help you with revision and revising these a little bit. All the best, and that's the end of this scenario. We'll come with our next scenario, which is post-TURP bleeding, in our next video. I wish you all the best and hope you all get a national training number. Take care.